All right, so there's a variety of tools that are available for speech pathologists who are looking at screening velopharyngeal closure, and we'll go through each of these really quickly. This is the C-scape. You can see that there is a nasal olive here with tubing that goes into the base of this beaker type chamber, and there is a little cork. You can see it right here at the top, and here you can see it kind of going up the tube. What it does is when the individual, you put this little cork in their nose, as you can see, and then what you would do in theory is have the individual repeat syllables like pa 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 or ba 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 ba. For those sounds, we should be able to produce those sounds without any nasal airflow. Now, keep in mind, at the end of all utterances, you and I, with adequate velopharyngeal closure, will release extra residual air from our nasal cavity at the end of a phrase. So be sure you're not, if you see it kind of flying up the tube here, be sure that it's not just always at the end of a phrase. If it is at the end of a phrase, that's normal. The problem I find with this product is that last time I checked, it was right around $100. The problem is it kind of rewards the feature that you don't want to have happen, right? So a kid doesn't want to have this little cork stay at the bottom. It's way more fun to watch it go up, right? So sometimes you have to set up a game so that you have to do your practice with the C-scape, keeping it low, and then at the end of our utterance, we're going to go ahead and let the kid let this little cork go up because that's fun. You can see he's laughing. He's having a great time as it flies up to the top. There's also a product that came out back in 2008, I believe. It's the Oral Nasal Listener. It's through SuperDuper. And basically you can see here it helps to amplify nasal emission and oral speech depending on where you're holding that microphone type utensil. So you can see that the speech pathologist wears essentially like the stethoscope type earbuds, and then they share this tube back and forth, and the child or the patient you're working with can wear that as well. Here they're holding a funnel under her mouth to try and amplify the mouth sounds, and here you can see she's using this tubing to amplify nasal emission. I kind of have the same concern with the Oral Nasal Listener as I do with the C-scape. The Oral Nasal Listener, I haven't priced it out in a while, but I believe it's close to $100 as well. It might be more than that. But it's a pretty expensive piece of equipment, and I think there are other tools we can use that have the same outcome, but they are not nearly as expensive. So I don't have one of these. I do have a C-scape that I inherited when I started working at the hospital. I've used it less than 5 times in the 8.5 years I've been there, so I don't find either one terribly necessary. There's definitely some cheaper alternatives. You can see here's one. You can just hold a dental mirror under the child's nose and see if it fogs, and so that can let you know if there's any nasal air emission. Now, people who don't like these mirror tests complain that you're now making a visible correlate to something that's an audible feature, and that's probably true, but if it fogs, air is leaking out. If it doesn't, then they're airtight or possibly plugged. So sometimes I'll actually use a nasal mirror before doing any more significant testing like nasometry or pressure flow, just to make sure that they are getting air moving through the nasal cavity. But so you just hold it right under the nose. Again, same thing with the C-scape. You want to be sure that you're not getting alarmed if there's fogging on the mirror at the end of a phrase. You're always going to have extra air that's just released. So be careful with your interpretation of this task. My favorite, if I'm going to use some sort of an amplification method, is a straw. So you can see, these are some of my colleagues several years ago who are good sports. But you can see if she was the individual or the patient that we were concerned about, she's holding the straw by her nose. The speech pathologist can then take, it's a bendy straw, can take it by her ear and see if she hears it. You can also use it for feedback. Now, the one thing that is not good about this image is you'd probably, instead of, you can see how this straw is kind of kinked to get into her ear, I would probably cut the straw and change the angle so that she can hear it easily. And so you can get a bag of 100 straws for $1. So this is probably my preferred tool if I need one. It's disposable. I don't have to worry about cleaning it properly. Kids like it. They think bendy straws are fun. So I think that this is probably the best tool, for me at least. Other people may have other preferences. And then one of the tests that we can do, and it's not a speech-related task, but it is a way to see if the individual can separate the oral and nasal cavities, is just a puff cheek test. And so you can see here he's just at rest, and here he's puffed up his cheeks. Some kids, if they have velopharyngeal dysfunction, they can't puff up their cheeks. They'll try, but you'll see them try and puff, and they might puff out air in the just in the sulcus in between their mandible and their cheeks, lower cheeks. They might be able to hold air there. But you can see in his case, he's got all the air in his cheeks, as most people do when they puff out their cheeks. Now, kids with clefts are clever, and they can figure out a way to puff out their cheeks, sometimes even if they don't have good velopharyngeal closure. So we can be smarter than them and do the tongue anchor test. So again, here's the little guy, whoops, at rest. Here he's puffing his cheeks. I usually will go have him at rest, have him stick out his tongue, and what that does is it pulls the tongue forward and eliminates the ability to either lift the palate posteriorly with the tongue, kind of pushing it up, or it also prevents the individual from plugging a fistula anywhere on the hard or soft palate if you've got your tongue sticking out, and then you have them puff their cheeks. So he, again, was airtight. You can see his cheeks puffed. He's able to seal off the oral and nasal cavities at the velopharynx. He's not leaking anywhere into the nasal cavity. But this one, it's kind of challenging. Even some kids who have adequate closure can't figure out how to coordinate this movement. It's not a test you can do during speech tasks, so you can't have them, you're not assessing velopharyngeal closure during production of any phonemes, but you can kind of probe to see if there's any little leak somewhere that perhaps you missed on your oral exam. So once we've done these different tasks, we've screened velopharyngeal closure, we want to ask ourselves, can the individual generate oral pressure? And so the answer is yes, if they were able to produce the consonants or oral substitutions within the oral cavity with appropriate oral pressure. The answer is no if you noted weak pressure consonants, you noted nasal air emission, you noted compensatory articulations. Now, just because they're doing compensatory articulations, that does not mean that they don't have adequate closure, but it might be a reason, if you are a speech pathologist in the community versus a speech pathologist at a cleft specialty center, it might be a reason to refer to a team for further evaluation just to make sure that the structure is intact. If they can't generate oral pressure, or if you notice atypical resonance, you would definitely want to, at that point, refer the child to a cleft palate team or a VPI clinic for further management. Now, one thing I want to make really clear is this referral. I mean no offense to our otolaryngology colleagues, but many times speech pathologists may refer to an ENT when you hear a concern of velopharyngeal function. We certainly want to refer to our ENT colleagues when we have a voice disorder, but voice refers to the larynx. Velopharyngeal dysfunction is the palate. And so many times ENTs in the community don't have frequent interactions with speech pathologists or access to a speech pathologist who can help analyze the speech patterns carefully, you want to be sure you're referring to a whole cleft palate team where the child will get an evaluation from a speech pathologist, a surgeon, and they'll evaluate the child together to determine whether or not velopharyngeal function is adequate. I can't tell you how many times I've had kids who the parents were referred to just a general ENT who's probably excellent, but they've missed the features of velopharyngeal dysfunction. And in fact, just this week, there was a little boy who came into my clinic, and they had seen an ENT in their town. It was a smaller town outside of Houston, but they went to the ENT at the recommendation of the speech pathologist at their school, and he looked at the child's palate and said, oh, it's just a high-arched palate, nothing to be worried about. Do a little more speech therapy and we'll see how it goes. Well, the parents rightfully weren't really satisfied with that recommendation, so they ended up coming to see our team, and sure enough, the child is hypernasal, has nasal substitutions, just tons of compensatory patterns, and you look in the child's mouth and they have a zona pellucida, a bony notch in the hard palate, and a clearly bifid uvula. So this child has a submucous cleft palate. So the child was misdiagnosed at the other ENT's office, and this was a very clear case of a submucous cleft palate. Listening to the child, you can be very certain that the child had velopharyngeal dysfunction, and thankfully the parents weren't satisfied with the initial evaluation and they went on to see us. But I would say this happens fairly regularly. So when you're thinking about a referral, if you're ever concerned down the road about a child's resonance, you really need to send the child to a cleft palate team. And again, you can find the information for your nearest cleft palate team by going to cleftline.org, the family-friendly side of the American Cleft Palate Craniofacial Association, and you can find all the listings within the United States and even some countries internationally where the families can get a good comprehensive workup by the team. Okay.